lesions are very common, and due to flow turbulence, the atherosclerosis tend to occur at bifurcation sites. About 20% of all coronary lesions are bifurcation lesions, and hence knowing it is more important. The bifurcation techniques are varied, and there was no standardization previously. However, now it is proposed to have a standardized reporting of bifurcation procedures. Why is bifurcation important? Because stenting a main branch results in plaque shift and change of carinal angle towards the side branch, and the TVR since long has remained high at bifurcation sites, about 3 to 4 times more. The side branch TVR or target vessel failure is reported up to 20% in the BMS area. With the advent of drug-eluting stent, it was thought that it would be a thing of past, but however, even with the initial studies with drug-eluting stents revealed that the side branch failure was in tune of 10 to 15%. Now let us see what is the bifurcation. So the bifurcation, as by definition, is any lesion that is adjacent or involves a major side branch, and the definition of side branch is quite vague. It is a branch which supplies a large portion of myocardium, a sizable portion of myocardium, and compromise of which could lead to deterioration in LV function as at discretion of operator. Now side branch usually subtends a substantial myocardium, and hence the size of the side branch usually correlates with this. So any side branch more than 2 millimeter is considered a significant side branch. Now let us go through the main definitions here. The proximal main vessel, the polygon of confluence where the two branches divide, side branch, distal main vessel, the bifurcation or carinal angle. It is the carinal angle as defined here is the main thing which can decide about. So syntax score should be carried out in each of these lesions. The syntax 1 score did not give consideration to bifurcation lesions, and a syntax score overview, the bifurcation Medina type 1-1 was given 2 points. Syntax 2 score gave more importance to clinical features also, and hence a syntax 2 score is more important whether a patient should be given for CABG or PCI. Now there is a European bifurcation club which tries to uniformize the stenting technique, and there are EBC trials carried out where provisional stenting or one stent technique called provisional approach. Implantation of one drug-eluting stent in the main vessel with additional balloon dilatation or stent implantation of the side branch only in case of need. It is recognized as a gold standard. However, the use of two stent implantation technique is advised to treat in selected patients with complex bifurcated lesions with relevant and significantly diseased side branch. So what are the pooled trials of EBCs? The pooled trial definitely shows that the mortality and long-term mortality both are decreased with provisional stenting group as compared to two stent. Two stent has a mortality of 4% and a long-term mortality of about 6.3% as compared to 2.4 versus 3.3 in provisional. So provisional is a simple technique where you stent the main branch and the distal main branch and treat the side branch only if necessary. So the stepwise approach in this is wire both branches, stent the main branch across the side branch, do a proximal dilatation and recross the wire. We'll come to that later, and if necessary do a kissing balloon. The pros and cons of kissing balloon, final kissing balloon and dilatation of the stent struts we'll discuss later. There is one more trial that while doing the balloon in the side branch, use of a drug coated balloon in side branch may probably decrease the incidence of restenosis in side branch where we have done only POBA. These are all the meta-analysis of trials done and shows that the drug coated balloon in side branch probably reduces the side branch. Now in provisional approach, if there is a side branch compromise, you have to do a bailout stenting. The approach is to put just one stent, dilate the side branch and come out. If at all there is threatened side branch closure, severe osteal pinching of side branch more than 90%, TIMI flow grade decreasing in side branch and dissection greater than type A, or if you do the FFR, if it is less than 0.75, you need to stent the side branch. Now, which are the cases where we should go for a two stent strategy upfront? So 80 to 90% of patients usually require a provisional approach only. Our intention should be to treat only the main branch and side branch only if necessary. When to go for upfront two stent strategy? There was a trial called Definition and Definition 2 done for that, and definition criteria required one major and two minor criteria to assess a bifurcation lesion as complex. The major criteria were that side branch length, lesion length more than 10 millimeter and more than 90% stenosis for non-left main and more than 70% stenosis for left main, that is circumflex if it is the side branch. So side branch lesion length more than 10 millimeter and more than 90% stenosis for non-left main or more than 70% stenosis for left main in side branch are major criteria. The minor criteria are moderate to severe calcification, multiple lesions, bifurcation angle less than 45 or more than 70. Main reference vessel diameter less than 2.5, the main vessel being small, thrombus containing lesion and main vessel lesion length more than 25 millimeter. However, of this, the sub-analysis is the major criteria are more important. Side branch lesion length more than 10 millimeter and significant disease more than 70% and a bifurcation angle of more than 50 is important. So definition 2 results in a population of 653 patients with de novo complex bifurcation lesion as defined by this criteria. The intervention was two stent approach. The method used was TK crush in most of the patient, while half the patient were treated to provisional approach, and target lesion failure was 10% versus 18%, and hence a two stent approach was better in definition 2 criteria. So here definition 2 had 660 patients. Majority of bifurcation lesions were LAD diagonal, which we see in the real world, followed by distal left main. Target lesion failure was significantly higher in provisional stenting group as compared to two stent group, 11.4 versus 6.1%, and majority of TVMI, target vessel MI, occurred within first 30 days. Provisional stent 6.5% versus two stent 2.4%. And now with the newer generation of DES coming, pooled data showed that two-stent technique was significantly decreased MACE, TVMI, TVR compared with provisional techniques, and there was no significant difference of all-cause mortality. The decay crust technique significantly decreased MACE and TVR compared with other two-stent techniques. So we'll discuss the major techniques to be used in this. So we'll come to first provisional stenting strategy. Wire both the main and side vessel branches. Stent the main vessel. Crossover stenting from the side branch with at least 8 millimeter in the proximal main vessel. Despite whatever the lesion is, at least 8 millimeter should be done, so proximal optimization can be done. So this stent, the side branch wire has to be jailed, and the stent has to be 1:1 with the distal main vessel. Then a proximal optimization balloon should be done with a NC balloon with size 1:1 with the main vessel, and it should be taken care that it does not cross the carina. Then distal side branch rewiring should be done. Now the preferred technique is leave the wire, side branch wire in the side branch only, remove the main vessel branch with an angle and cross it, and then remove the side branch wire and with a loop go in the main vessel. So that is exchanging the wires from side branch to main branch and main branch to side branch. Then comes the kissing balloon inflation. So after that, this stent strut of the has to be opened. So once the side branch is wired, ideally it should be done from most distal most strut, the carinal strut, and then it should be dilated with the balloon with 1:1 with the side branch thing. The advantages of doing a side branch balloon are that it abuts and properly expands the stent into side branch ostium, so that there is no gap left between side branch ostium and the stent where a thrombosis can occur. The disadvantages of this is probably that it can cause a dissection in the side branch and convert a one stent strategy into a two stent strategy. So opening up these cells should be gentle with 6 to 8 atmosphere, and final kissing balloon should be done, followed by a repeat pot to correct the distortion caused by these two balloons should be done. So this is the provisional strategy. If after this provisional strategy, if the side branch flow is TIMI3, the lesion in side branch is less than 75%, or FFR is less than, lesion in side branch is less than 70%, and if the FFR is less than 0.75, it can be safely left alone. Now the other two techniques which we are going to discuss today, which are more advisable. So the two stent strategy, T-tap or T or T-tap strategy. Now the steps still these are similar, repeat pot, these are similar. So once you have inflated, opened this strut in the side branch, now the side branch requires stenting, or we have decided to go for a side branch stent. A T stenting is done when the angle is exactly about 90. However, very less chances that we get this 90 angle, and mostly a T-tap has to be done, where the stent edge has to be exactly on the proximal marker at the stent, so that side branch ostium is not missed out. And you have to keep a balloon in the distal main branch. The stent is sized to side branch 1:1, after which one stent is deployed. Then you have to inflate this side branch balloon coming back 1 or 2 millimeter at very high atmosphere, about 16 to 18 atmosphere. Then do pull back the main distal main branch balloon and do a kissing, and then do the repeat pot. So there is a neocarina formed in the distal main branch, and it is about 1 or 2 strut at the max. Inverted T-tap, we can go for inverted T-tap when proximal main vessel to side branch stenting can be done. The stent size is according to the 1:1 with the side branch. Then pot followed by rewiring of the main vessel. Then a stent in T or T-tap method. Then recrossing and final pot. Kissing balloon and final pot. Now culotte stenting. Culotte stenting is another method which was used. However, its results versus culotte are inferior, and hence it is mostly abundant in recent practice. So DK crush is more cumbersome. However, the long-term results with DK crush are much better. In culotte stenting, probably it can be reverse culotte or culotte, in which you stent the main vessel to side branch, then do a pot in the main vessel, recross to the main vessel, dilate the main vessel, just in T-tap like this, reverse culotte, as in reverse T-tap, and then put a stent from main vessel to distal main vessel. So there is a overlap of about 8 to 10 millimeters of both the struts, and then recross the side branch and do kissing balloon and final pot. Now DK stenting. In DK stenting, you dilate both the vessels first, side branch and distal main vessel, then put a stent in side branch, so that about 2 to 3 struts are overlapping in the main branch. Simultaneously, you keep an uninflated balloon in the distal main vessel. Then you inflate the side branch stent at a nominal pressure, and then pull back a little and inflate it at higher pressure. After that, you remove the wire and balloon from the distal side branch and crush the stent with the balloon, which was 1:1 with distal main vessel. After crushing, you recross the stent strut. Here you don't have to cross from the distal carinal but non-distal carinal strut, probably from the mid or proximal. Then dilate the side branch strut again, the crush strut again, and do a kissing balloon. Then main vessel stenting is to be done 1:1 with distal main vessel, followed by pot in the main vessel, size 1:1 with the main vessel size. Then again you have to rewire the side branch and do final kissing, and then final pot. So this is how a crush looks, with some stent strut crowding in one of the portions and a neocarina formation. Thank you.